Welcome to this explainer. Today, we're diving into something completely fascinating. We're going to explore the extreme, cascading physiological lengths the human body goes to just to survive severe physical trauma. We're literally looking under the hood at the body's ultimate, absolute last resort survival protocols. So think about this for a second. What actually happens to our metabolism when the body is pushed to the absolute brink? When massive trauma occurs, the body doesn't just passively bleed or, sit quietly. No way. It wages this violent, highly orchestrated biological war to keep you alive. It's a really incredible story of crisis, rapid adaptation, and a desperate bid for survival. Let's take a look at exactly how this story begins. Section 1. The body under siege. Okay, so in the clinical world, the exact moment the body suffers massive trauma and rapid blood loss, which we call hypovolemia, is often referred to as the ebb or shock phase. This is the inciting incident. Because blood volume has suddenly just dropped off a cliff, the body clamps down at the microscopic level. It triggers localized and splanchnic, or abdominal, vasoconstriction. Basically, it's squeezing blood out of your belly and extremities to keep it in the central vital organs. But here's the catch. This starves the surrounding peripheral cells of oxygen. Transport of essential nutrients is severely impaired. The cells experience a massive drop in ATP, their primary energy source, forcing them into a highly inefficient anaerobic survival mode. And because they're surviving without oxygen, you get a dangerous buildup of acid, like lactate and hydrogen ions. Ultimately, this leads to cellular swelling and failure. It is a wildly desperate situation. But, as you can imagine, the body cannot sustain that localized cellular crisis for long without dying. So, the fire alarm is sounded, initiating an incredibly powerful systemic reaction. Section 2. The immediate alarm response. Think of your nervous system and your hormones as a team of frantic first responders, literally kicking down the doors to save the brain and the heart at all costs. First, that sudden drop in blood volume and pressure, it's sensed by internal monitors called baroreceptors. They immediately signal the brain, which leads to step 2, a massive increase in adrenergic output. Step 3 is the rapid, explosive release of norepinephrine. This triggers peripheral vasoconstriction and spikes the heart rate to salvage central blood pressure. Finally, metabolic substrates are rapidly mobilized to give the body the fuel it desperately needs to survive just the next few minutes. What's really fascinating here is how these specific first responder hormones act synergistically. They work together perfectly. Epinephrine handles the vasoconstriction while breaking down glycogen for quick energy. Then cortisol steps in to enhance lipolysis, which is breaking down fats, and it promotes gluconeogenesis, the creation of brand new glucose. Glucagon comes in and further accelerates that hepatic gluconeogenesis. So together, this hormonal trio completely floods the bloodstream with vital energy while simultaneously keeping blood volume up. It's just a beautifully coordinated biological defense mechanism. But unfortunately, here's where the story takes a rather dark turn. The derangement begins. If the patient actually survives the initial shock, they transition from that acute ebb phase into a chronic, highly destructive recovery phase. Section 3, the hypermetabolic flow phase. In a desperate bid to repair massive tissue damage and fight off potential infection, the body dials its metabolic rate all the way up to 11. We call this the flow phase, and it's driven by a cytokine storm. You can think of these cytokines, Tumor Necrosis Factor-alpha, interleukin-1, and interleukin-6, as incredibly aggressive drivers of systemic inflammation. They actually reproduce elements of the shock state itself. They cause fever, mobilize the immune system, and drastically accelerate the body's overall energy expenditure. And adding fuel to the fire, inducible nitric oxide synthase, or INOS, starts pumping out toxic nitric oxide and free radicals. The entire system is just burning incredibly hot. And to make absolutely sure the vital organs have enough fuel for this hypermetabolic fire, the body does something brilliant, but extremely dangerous. That massive flood of catecholamines we talked about earlier actually suppresses normal insulin release via alpha-2 receptors. Essentially, the body intentionally creates severe insulin resistance. Why? Well, to trap glucose in the bloodstream. It prevents peripheral tissues from using it, so it's strictly 100% reserved for emergency use by the vital organs and the brain. Which brings us to Section 4, starvation versus stress. Now, this is perhaps the most fascinating paradox of our entire discussion today. We so often think of trauma and starvation as similar energy-depleted states, but biologically, they trigger completely opposite metabolic strategies. In simple starvation, the body goes into hibernation mode. It slows down into hypometabolism to conserve energy. It relies heavily on fat stores, burning about 150 grams a day. And it fiercely protects its vital protein, losing only about 20 grams of muscle daily. Severe physical stress and trauma, however, cause hypermetabolism. The body aggressively cannibalizes its own skeletal and visceral muscle to provide amino acids for gluconeogenesis and to fuel the massive immune response. So a starving body protects itself. A traumatized body literally consumes itself to fuel the repair process. Section 5. The cost of survival. These short-term survival mechanisms are absolutely brilliant for keeping you alive in the first few hours after a trauma. But what happens if they're left unchecked? 240 grams per day. That is the massive, staggering amount of vital body protein a severely traumatized, hypermetabolic patient will burn off every single day if medical intervention doesn't step in to halt the stress metabolism. At that rate, a patient undergoes severe muscle wasting, depleting up to 50% of their total body protein stores within just 3 weeks. And the consequences of this catabolism are fatal. Without enough protein, the intestinal mucosa atrophies, fluid retention sets in, the immune system collapses, which leads to severe infections, and eventually multiple organ systems just fail. At the very same time, we see the acute phase response taking a massive toll. The liver radically shifts its manufacturing priorities. It stops making standard maintenance proteins like albumin, causing your serum albumin levels to absolutely crash, and instead it frantically pumps out acute phase proteins to manage the trauma. C-reactive protein, or CRP, which is normally sitting under 8 milligrams per liter, skyrockets to over 200 in severe trauma. The liver is just desperately trying to synthesize fibrinogen for clotting and complement for immune defense, which of course further drains the body's resources. And this leaves us with an absolutely crucial clinical takeaway. The fundamental approach to management is to recognize overt and impending shock in a timely fashion and to intervene emergently to restore perfusion. Basically, understanding this violent, cascading metabolic response is the only way clinicians can step in and save a life. By restoring blood volume and stopping the inciting trauma, they send a signal to the brain that the war is over, effectively shutting down the hypermetabolism before the body completely destroys itself. It really leaves us with a provocative thought, doesn't it? Could the very biological mechanisms, perfectly designed to save us in a moment of crisis, be the exact same mechanisms that kill us if left unchecked? Thank you so much for joining me for this explainer. Keep asking questions, and we'll see you next time.